So I can start now, na?
Yes, sir.
So sorry for the disturbance. Actually, this is the physiological basis of ECG diagnosis, sir. And sir, this is one of the slide. I got it from Professor Marzilli. He's a renowned cardiologist of Italy. Actually, he delivered a lecture in a ESC Congress in 2011. And his concept was that Copernicus revolution in solar system. Actually, this was the revolution as because this was the concept against the concept of Ptolemy. Ptolemy told that the earth at the center of the solar system, but Copernicus told that the sun at the center of the solar system and all the planets round around the. So this was the revolution of Copernicus over the Ptolemy in the 16th century. So this is the solar system. The solar system, existence of the solar system depends on the existence of the sun. This was the concept of the Copernicus revolution. And I got this slide from Professor Marzilli of Italy. And another slide I also got from it that the same electrical system, the same solar system is also existing in our body. That was actually proposed by the Inthoven. He told that human body represents a large volume of conductor having the source of electrical activity at its center, and that is the heart. So heart is the sources of the electrical activity of the body. Body can be compared with the solar system. Heart can be compared with the sun, and it is surrounded by the multiple systems of the body like the neurology, electrolytes, endocrinology, and respiration. All the systems are nourished by the heart, and existence of all the system depends on the existence of the heart. So heart is the center of the body, and that is the sources of electrical activities of the body. And same, the heart does two things. The mechanical events, that is the main target or main function of the heart. That is the pumping of the heart. That is done by the systole and diastole. And it is actually translation of the electrical activity of the heart. So heart can be compared not on the sources of the electrical source, that is the generator. Heart can be also compared with the transformer. It can transform the electrical activity and convert it to the mechanical activity, that is the systole and diastole. And the most important thing is that for the understanding of the ECG, the electrical systole follows the mechanical systole. That is the mechanical activity is preceded by the electrical activity. This is the actually synchrony of the electrical mechanical activity of the heart. P wave represents the atrial depolarization, and P wave follows, that is the atrial systole. Same way, the QRS complex initiates or marks the ventricular depolarization, but the ventricular mechanical systole consists from the R wave to the T wave. That is that is the systole and that is the depolarization and repolarization. So this is the relation between the electrical activity with the mechanical activities of the heart, and this concept is very much important during the ECG guided echocardiography. And this is another slide. This is a very well-known slide, actually presented in all textbooks of the physiology like the Guyton, Gannon, every textbooks of the slide. Here there is a coordination between the interrelationship between the electrical activity, hemodynamic activity, and the all other mechanical activities of the heart. We can see the ventricular depolarization marks the onsets of the mitral valve closure and aortic valve opening, that the first heart sound, and again the ending of the T wave marks the second heart sound. So this is how there is a coordination between the electrical, mechanical, hemodynamic activities of the heart. So this is the actually electrical activity initiates, coordinates all the physiological events within the heart during the cardiac cycle. And one cardiac cycle is the unit of functional unit of the heart activity. So this is how the electrical activities are. So there is another chapter of a textbook of the ECG written by Andrew T. Reisner and others. The title of the chapter is The Physiological Basis of the Electrocardiogram. They told ECG understanding needs electrophysiology of the single cell, propagation of the electrical activity through the myocardium, physiology of specific structure of the heart, like the atrium, SA node, AV node, like this. There is physiology of each structure of the heart. And finally, all that events that leads to the measurable electrical signal, that is the ECG. So understanding of the ECG knows understanding all the activities of the heart, electrical and physiological activity of starting from the single cell to myocardium to specific structure, and finally the recording of the electrical activities of the heart. And thus, contrary to the general belief, we have a general conception that abnormal ECG is equal to abnormal heart. But this is not true, as because ECG does not directly measure the electrical voltage, does not directly measure. It indirectly measures the electrical behavior of the myocardium. And there is no single cause for abnormal ECG. There are multiple causes or differential diagnosis for the abnormal ECG. So abnormal ECG does not mean the abnormal heart. The extreme examples of these kinds of the limitation of ECG is the stage D heart failure, where despite the stage D heart failure, the patient may have the normal ECG. So ECG does not always tell the truth or represent the condition of the heart. It always describes the physiological status of the heart, electrical behavior of the heart. So the correct dogma about the ECG, about the language of the electrical language of the heart, is that we must need correlation between ECG diagnosis and clinical diagnosis, must correlation between the ECG diagnosis and clinical diagnosis. ECG diagnosis and clinical diagnosis are not the same. There is some example. This is how the physiological basis helps to give the diagnosis. This is one of the ECG of a patient. This patient told he has got the paroxysmal palpitation different time, but most of the time always he has got this kinds of the normal ECG. But once upon a time, the patient has got chance to record such kind of the electrical, that is the some kinds of the pulsation in the throat, that is the neck. So this is a proof. This physiological finding is a proof this patient has got some of the that is the loss of synchronization within the heart, and that gives rise to the retrograde pulsation in the neck. And this is one of the classic example of the SVT, and particularly the AVNRT, where both the ventricles and atrium contract simultaneously. This is one of the example of the ECG of SVT, that is narrow complex regular tachycardia. Narrow complex regular tachycardia, we can see only the QRS complex. There is no evidence of the P wave, so the P waves must be within the QRS complex. As per example, we can see from this that is re-entry phenomena, there is both the ventricle and the atrium contract simultaneously in case of the AVNRT, or the P wave may be just after the QRS complex, depending on the speed of retrograde activation of the impulses from AV node to the atrium. So depending on the condition, most of the time we cannot see any of the P wave, and at that situation, there will be simultaneous contraction of both the ventricles and atrium, and that gives rise to the such kinds of the neck pulsation. There is no alternative diagnosis or differential diagnosis is not needed in such a situation when there will be such kinds of the ECG with these kinds of the neck pulsation. And even this normal ECG does not exclude the presence of the disease when this kinds of the neck pulsation is present. So this is the beauty of the physiological findings of the ECG. And another kinds of the physiological findings are there will be irregular neck pulsation that can be happened when there will be irregular dyssynchrony between the atrium and ventricle, as it can happen during the complete heart block. So the neck pulsation can also dictate the presence of the complete heart block. This is one of the example, and this is another the example of physiological findings. And again, these kinds of the finding can be even help to the differential diagnosis of the wide complex tachycardia. When the patient has got the wide complex tachycardia, but these kinds of the regular neck pulsation, he may have the aberrant supraventricular contraction, that is the SVT, the broad complex QRS tachycardia. But when the broad complex tachycardia will have got such kinds of the irregular neck pulsation, possibly there should be the VT. So even these physiological findings, that is neck pulsation, can help to differentiate within the that is the wide complex tachycardia when it present. This is not expected to present in all the cases, but when it present, he had got the tremendous value for the differential diagnosis. So this is the beauty of the electrical, that is the physiological findings for the differential diagnosis of the ECG. So some of the differential physiological clues also help to give the diagnostic clue. As for example, when there will be syncope like the neck pulsation, some of the patient may have the syncope with the preceding, that is the taking, that is palpitation may follow the syncope. In that case, this leads to the diagnosis, that is a very rapid ventricular tachycardia or atrial fibrillation or WBW syndrome or AV block or sinus arrest, that is palpitation follows syncope. When palpitation follows syncope, these are the differential diagnosis can give. And again, when there is a long-standing recurrent syncope without collapse lasting for more than 3 years, that indicates presence of the SVT. But when there is a syncope, every time there is collapse, this can be the VT. So this is the correlation of the physiological findings as well as the some ECG evidence can give the clinical diagnosis in addition to the ECG diagnosis. So abnormal ECG is not the abnormal heart always. Abnormal ECG means the abnormal physiology. That is true. There should be some abnormal physiology within the heart. There may not be the structural heart disease. As for example, these are the examples. As for example, some of the patients may have the WBW syndrome. There is the WBW pattern ECG without symptom, long QT syndrome without clinical problem, Brugada syndrome asymptomatic, that is the PVC is asymptomatic, atrial fibrillation asymptomatic or AV block. So these are the examples, these are the abnormal ECG findings, but does not always the abnormal heart. These are the examples of the abnormal physiology. So before going to comment about the ECG, we must have some of the self-check, like we should not, don't make up your mind to give the comment too early. We have to avoid premature jargon conclusion about the ECG. Try to look at the previous ECG and don't simply give the eyeball measurements when it is required. We have to use the caliper and to give the actual measurements, as because millisecond by millisecond is very much important sometimes. And most important, we have to try to find out the AV relation, P, QRS and PQRS morphology. And finally, you have to create a differential diagnosis and must not always you have to consider the clinical context. So these are the actually basic rules, self-check rules for giving final comment about the ECG. We have to avoid the jargon conclusion about the ECG. So these are the some physiological properties of the heart or electrical properties of the heart: automaticity, excitability, conductivity, and contractility. All these physiological properties or physiological function or electrical function of the heart can be explained by the ECG. Actually, whole ECG is the explanation of the physiology. This is one of the example when I can say that is the what physiology it tells this ECG. From this ECG, we can see about the physiology of heart. We can see two kinds of the automaticity. Two kinds of the automaticity. This is the automaticity of the sinus rhythm. This is the sinus beat, PQRS, 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 but this is one of the abnormal beat. There is no P. This is not the not sinus beat. This must be, that is the PVC. So there are two kinds of the automaticity, that is the sinus automaticity and another ectopic automaticity from where these PVCs are coming. So these two kinds of the automaticity can be explained from this ECG. And another physiology we can see, this PVC, there is a slurring at the downward, that is the at the ST segment or the one part of the T wave, that is the down part of the T wave. So this is the presence of the, possibly this is the retrograde P wave. So this patient also had got the retrograde conduction of the AP node. So from this ECG we can see that is the automaticity, normal antegrade conduction of the AP node, as well as the retrograde conduction of the AP node. And this WPW, that is this patient may have the both kinds of the abnormality. So we can see also there is a narrow complex QRS and also the broad complex QRS. This narrow complex QRS presents, that is the normal conduction system conduction, and this represents, that is the this QRS complex actually not using the normal physiological conduction system, that is the conduction through the myocardium. So they are taking the longer time, and producing the abnormality wave. So these are the examples. So these are the physiological findings of the physiological properties of the heart we can see from this single ECG. And from this, depending on the narrow complex and the wide complex ECG, we can classify the ECG. There is a normal QRS wide, intermediate QRS wide, and the broad QRS complex, depending upon the speed of conduction, as because from the ECG or from the physiology, you know, that is the different parts of the heart has got the different speed of the conduction. As far as there is a specific types of the conduction velocity in the atrium, conduction velocity in the ventricular muscle, conduction velocity at the Purkinje fiber, that is the highest. So depending upon the QRS width, we can also comment, or we can also give some idea about the physical properties or physiological properties of the conduction system of the heart, how this electrical impulse is going from here to there, and what are the system they are using, whether they are using the normal physiological conduction system, whether the physiological conduction system is okay or pathological, or whether the impulse is using the abnormal physiological system, that is the myocardium or not. So depending on the width of the QRS complex, we give some physiological properties of the heart also. And the automaticity of the heart, automaticity is one of the properties, and every parts of the heart has got the automaticity. The highest automaticity rate is the SA node, that is followed by the AV node, that is the 40 to 60. Ventricular muscle and the Purkinje system, from about there is a hierarchy of rate of automaticity from SA node downwards. So there is a definite specific types of the automaticity at the different parts of the heart, and this automaticity depends upon the speed of repolarization, that is depolarization, during the phase 4 of the action potential. This is the phase 4 action potential of the non-pacemaker cell, and this is the phase 4 action potential of the pacemaker cell. This is going upward, sloping upward. There is a spontaneous depolarization happening during the phase 4, and this property represents the spontaneous depolarization. And when there will be highest rate of the spontaneous depolarization of a single cell, that can be have got some the abnormal automaticity. So like this is the actually non-pacemaker cell automaticity, that is the horizontal type of the phase 4 depolarization, and this is the sloping upwards of the phase 4 depolarization. And when this kind of the automaticity appears at the different parts of the action potential, they can produce the different kinds of the ECG abnormalities or arrhythmia. Like this is the appearance of the abnormal automaticity, that is high speed of automaticity during the phase 4, or this is appearance of the abnormal automaticity during the phase 3 of the action potential, or during the latter part of the phase 4 of the action potential. And depending of appearance of such kinds of the abnormal automaticity at the different parts of the action potential, there is different nomenclature, and all these kinds of the abnormal appearance of the automaticity can give abnormal types of the ECG or different types of the arrhythmia. And this is possible when there will be some pathology of the electrical environment of the heart. And not only the abnormal automaticity, the heart has also some kinds of the refractoriness or excitability. That is, refractoriness or excitability is another example, that is another physiological properties of the heart. From the ECG, we can see there is absolute refractory period and the relative refractory period. The absolute refractory period is actually last from the beginning of the QRS complex up to the mid part of the T7. This is the absolute refractory period. And in action potential, this is phase 0, phase 1, and phase 2. And in ECG, the last part of the TOF, and in action potential, it is the phase 3 or phase 4 of the action potential that represents the relative action potential. So this refractoriness or excitability of the heart can give some of idea about the some kinds of the ECG abnormalities. So determinant is the determinant of excitability of the refractoriness of the heart depends upon the stimulation strength of the any kinds of the impulse or phase of the action potential when these kinds of the stimulus is going to the heart. So these are the two determinants whether these kinds of the abnormal impulse can give abnormal response of the heart. Actually, the response of the heart depends upon several things like this. If the impulse is strong enough and is appear that is actually attributed during the relative refractory period or the resting state, there will be new action potential. If the stimulus is weak and actually imposed on the resting state or relative refractory period, no response. But whatever may be the strength of the stimulus, even it is strong enough, it is applied on the absolute refractory period, there will be no action potential. There will be graded response, only the graded response. So new action potential actually appeared when there will be strong stimulus on the resting state or the relative refractory period. And this is how the heart responds to any kinds of the abnormal impulses, whether intrinsic or extrinsic. And depending on this is one of the example. We can see these are the some distortion of the T wave. Distortion of the T wave, it represents some kinds of the P wave coming from the atrium or SA node. It appeared on the, that is the just latter part of the T wave, and this is possibly the relative refractory period. So this T wave is not conducted. So this T wave is not conducted as because this P wave is not conducted as because this P wave is imposed on the relative refractory period. So this is not conducted. And this is the actually premature atrial activity as because this is early. If you compare this P wave and this wave, this is early, thus not here. If it were here, we can consider it the second degree T wave. But if it is here, so this ECG actually taken from Abdullah Jamil's ECG. He was posted in the WhatsApp. So I have taken from there. So this is one of the examples that is blocked PVC, that blocked APC. That is the APC is blocked in the T wave. That is the relative refractory period of the T wave. And this is one of the example how the relative refractory period helps to prevent the some kinds of the abnormal conduction of the P wave. But this relative refractory period sometimes can be widened, can be prolonged. As for example, this is one of the example. This is the long QT. Here the T wave is lengthened, ST segment is lengthened. So there is the prolongation of the QT interval, prolongation of the systole, prolongation of the relative refractory period. So the heart electrical system is exposed to the premature beat to interact, and they can be conducted and produce some kinds of the arrhythmia. This is one of the example. This is one of the example where I don't know how this was actually produced, either abnormal automaticity or triggered activity or re-entry, but this represents some kinds of the chaotic electrical activity where there is no definite cardiac cycle, there is no definite or defined cardiac cycle, so there is no cardiac output, no pulse, blood pressure. So this is the chaotic electrical activity, either ventricular fibrillation or polymorphic VT, but this is the chaotic electrical activity. And as there is no cardiac output, no blood pressure, the patient is clinically dead. But still the patient is electrically alive, clinically dead, but electrically alive, as because heart is still working in this manner. But we are not getting the cardiac output, not getting the blood pressure, so patient is clinically dead. And in this situation, patient may survive even up to 10 minutes. Up to 10 minutes, this patient gets survive. And only 5% of the patient may have chance to back to the normal sinus rhythm spontaneously. Otherwise, the 95% of the patient will die if there is no immediate intervention within the 10 minutes. And each minute, there will be 10% loss of the survival chance, 10% loss of the chance of the survival. And there are 3 phases of this 10%. That is the 10 minutes time. That is the electrical phase 4 minutes, hemodynamic phase 4 to 10 minutes. And after 10 minutes, there will be the metabolic phase. There will be acidosis something, and almost the chances of recovery is irreversible. So this is the, but why I'm showing this type of ECG? Actually, this is the time when there is some electrical activities, and there is no electrical activities, but there is no mechanical actually performance of the heart, as because the electrical activities are chaotic, and we have to back this patient to the sinus rhythm. And how this is possible? By the electrical shock, which can give rise to the graded response during this time. That is the graded response, that is the defibrillation produce the graded response of the electrical activities. This graded response prolong the refractory period, And this prolonged refractive periods prevents the heart for the entry of the any kinds of the ectopic beats during the time. So there will be the graded response, prolonged refractory time, no ectopic entrance. So there will be chances of escape rhythm, that is the sinus rhythm. This is how the defibrillation works during this time. And this physiological concept is used for the therapy. And this is another ECG. And I'm trying to see what is, we can see from this ECG, what is the physiological concept from we can hear. This ECG shows there is the delta wave, that is the hybrid conduction over the ventricle, both from the accessory pathway and from the normal conduction system. This is the hybrid QRS complex. And this is another type of the QRS complex, not preceded by the P wave. So this must be the ventricular prevascular complex. So these are conducted through the accessory pathway as well as the normal conduction system, as the PR is short and there is the delta wave. And this is actually conducted through the myocardium, not produced, that is not initiated by the sinus rhythm. And this is conducted through the myocardium. So this is one kind of the physiology you can see. And another physiology you can see, there is a slurring of the T wave. So this should be the retrograde P wave. So this patient has got the retrograde evinodal conduction. In addition to the antegrade evinodal conduction, this patient also had got the retrograde conduction. So this patient may be presented with both antegrade, orthotopic, and antidromic SVT. So these are the physiological clues we can have, or we can predict from the ECG about the physiological status of the heart. And this is another ECG. Actually, I don't know its diagnosis. I have shown this ECG. I want to know this diagnosis from this forum and physiological explanation of these kinds of ECG. I have got some differential diagnosis, whether it can be sinus arrest, junctional rhythm, atrial fibrillation, or other than these kinds of, that is any diagnosis other than this. So this was the last slide of my presentation, and this slide is open for discussion. I am inviting any faculties to comment, but first of all, I want to invite Dr. Tushar. Can you make any comment? And Tushar will be followed by some of faculties. Can you give any comment about this diagnosis, Dr. Tushar?
Thank you, sir. This is 12-lead ECG, and there is no obvious P wave in any of the leads, but two broad complex QRS are present, which are coming at a definite pattern. Two QRS at an interval of at some interval, and these are coming. So to me, and if you follow lead V1, then the first QRS, the V1, the first QRS, the T wave in that QRS, there is some indentation, and it seemed to me that this is sinus arrest with two junctional escape. For me, this is sinus arrest with two junctional or ventricular escape beat in a pair. I am not in favor of atrial fibrillation. So for me, this is this patient must have sinus arrest with two junctional or ventricular escape beats.
Tushar, if you look at the lead AVF, the first beat doesn't have any P wave preceding it, so it must be an ectopic one. But after its T wave, in the later part, there's a P wave. P wave with first degree heart block, then the second beat is sinus beat, AVFA. Then there is a long pause, then an escape beat, again a P wave, they superimpose on the T wave of the preceding QRS.
That was I'm trying to say that V1 dekhe amar ba AVF dekhe amar tai mone chilo. The first one, that is the escape, or following that there is a P wave that might be non-sinus in origin, ectopic atrial rhythm, which is conducted with a first degree AV block type, and then again there is a junctional beat, and followed by again a non-sinus atrial activity, and this cycle is repeating. But it is not atrial fibrillation. Per se, it is not atrial fibrillation. One thing that I'm sure it is not atrial fibrillation. So I'm in favor of sinus arrest with junctional escape beat or junctional escape beat, basically.
Dr. Tushar,
Sir.
Finally, you want to have a comment from Rofik sir, but before that,
Yes.
anyone? Dr. Zamil? Or anyone want to make comment before Rofik sir?
Sir, I like to add something, sir,
All
with
right.
the permission. Govindo, sir.
I go with Dr. Wadud. What he said, most likely this long pause after that, after the long pause, the QRS complex is from escape bit from the junctional tissue, followed by T waves seems to be quite peaked. It might be that the next P wave of the next bit is superimposed on the previous T wave.
Thank you, Govindo.
Sir, I like to add something. It's a form of group beat. Atrial ectopics, some are conducted or some are non-conducted. Already Wadud sir mentioned AVF, lead AVF, there is a teeny P wave, small P wave, distorted the T wave. And also P wave, small P wave is also in V2, V3, V5, V4, V5, V6 as well. There is non-conducted and with junctional escape, followed by another atrial ectopics. It's a group beat.
I think,
Sir, Rofik sir?
yeah, I think
And an incomplete RBB also as well. Thank you, sir.
Sure. And I mean, we always get this ECG. Anytime ECG, we get an ECG, first of all, we need to determine where do I start? First of all, if you look at the QRS, it is wide. But if you look at lead V1, it is RSR pattern, and lead 1 R with deep S. So definitely it looks like a typical right bundle morphology. And that tells me that this is most likely supraventricular origin. So where do I start? I'm going to start with, if you look at lead V2, after where it is written V2, there is a QRS complex, but there is no P wave. But in the T wave, there is something. And that, so if I start with that P wave, I can make an assumption the way Wadud mentioned, that this is a sinus P wave conducted with first degree AV block. Patient has marked sinus bradycardia, we get junctional beat. But the question is, I always think about a little bit differently also. Another possibility can be that somebody has a junctional escape. If I start from the junctional escape, it conducts retrogradely, and then through a dual physiology enters antegradely. If that is the case, then I'll have to prove that it is negative in lead 2-3 AVF, which is difficult for me to do. But I will buy Wadud's explanation that start with the P wave on the T wave, first degree AV block, patient has marked sinus bradycardia followed by junctional escape beat. And the second explanation will be a junctional beat retrograde, which then conducts antegradely. To prove that, I have to look at a long rhythm strip. If I can find a place where this retrograde wave doesn't conduct antegradely, then my diagnosis will be confirmed that I am right. But I think Wadud's explanation is the one that is to go.
Thank you, sir.
Dr.
I'm stopping.
Rofik bhai, I have,
Yes.
yeah, I have one comment. I think I agree with you, but another possibility that when we see those two group beats, could be ectopic beats that one conduct, definitely it starts with junctional escape, then one ectopic beat that conducted, but the second one blocked. Is it possible?
Yeah, the question is,
and then again it goes to junctional.
Yeah. Oh, second, but we don't see any distortion on the T wave. That was the problem part.
Sir, sir, if you don't mind, sir, if we look at the ECG, sir,
Yes.
Following the second QRS, the T wave seems to be distorted, sort of distorted in lead V3-4.
Yes, I have to look at it.
Sir. Can you please show the ECG, sir? Is it possible, sir?
Again, I'm in trouble. I think I should stop.
Okay, sir. Okay, sir. Sir, is it possible that the way Adi sir was telling that following junctional beat, there is one atrial, there is one sinus or atrial beat, which is conducted with a slightly longer PR interval, and the next P that is somewhat distorted the T is non-conducted because it appears in it comes in the refractory period. Is it possible?
Sure, it's a possibility, yes.
Mhm.
So ultimately, underlying rhythm, what is this ECG rhythm? Underlying rhythm, either
Well, you
sinus or
cannot say,
junctional or
well,
sir?
okay. So if you agree with me and Wadud, my diagnosis will be sinus bradycardia with first degree AP block with junctional escape beats.
What
Thank you,
might be
sir.
the underlying cause, sir, here?
Probably patient has 6 sinus syndrome.
Six, sir. Thank you, sir.
But রফিক ভাই আমার একটা প্রশ্ন সেটা হচ্ছে কি যে I like their আতার ভাইয়ের headline, the physiologic diagnosis. We want to know what is the atrial mechanism of depolarization, what is the relationship of AV, and what is the ventricular mechanism, right? So if it is sign and patient has loss of consciousness ×2, right? The clinical context.
True,
So
true.
what is the most logical diagnosis? Because we need to next think what to do for the patient, because looks like there is junctional escape rhythm happening, heart rate dropping. I don't know the escape. I don't know the atrial depolarization that is happening time to time. It may be sinus brady and first degree AV, but the fact is there is junctional escape happening at times. So what do you do
Well,
with the loss of consciousness?
clinically, how old is the patient?
65, sir.
65. I mean, if you're somebody with syncope with this ECG, first thing that will come into mind is six sinus syndrome. Even though it's a relatively young person, but we do see six sinus syndrome in young people also.
And there is a right bundle also.
Of course. And if you look at the second P wave, there is a first degree AV block in that. So there is a little bit of conduction problem also.
Because I think I like your first explanation more, because first degree AV block and then going into junctional escape regularly, I don't know, it doesn't make sense to me. But rather a junctional escape with retrograde the atrial depolarization, that makes more sense.
Yes, I think that is because otherwise to explain that constant relationship is very difficult.
Yes.
You're absolutely right. But I wanted to put the other way around because it comes simpler.
Okay.